Oh, hello. Thank you so much for having me. I'm really excited to be here to talk about my research. I am an assistant professor in the School of Nursing at University of Delaware. And today I'm going to talk about a secondary data analysis I did looking at the weight implications of consistent bedtime in toddlers living in low-income communities. So routines surrounding healthy behaviors are established in toddlerhood and often are carried into adolescence and adulthood. So the establishment of health habits in toddlerhood is critical to the prevention of later obesity and chronic disease development. It's well established that poor diet and physical activity habits created early in childhood are associated with weight gain, both cross-sectionally and longitudinally. Additionally, several recent reviews and longitudinal studies have shown that short sleep duration is associated with future weight gain in children. However, the association between weight gain and different sleep parameters, such as sleep onset, is less studied, and consistent sleep routines have been related to multiple health habits within the home, and implementing consistent bedtimes is directly related to earlier and consistent sleep onset times. So sleep timing is of particular interest because it's modifiable, especially in early childhood. And in school age and preschool children, studies have shown that bed and wake time consistency may be a better predictor of weight gain than sleep duration, yet this has not been extensively explored in toddlerhood when these habits are first developed. So obesity-related disparities in race, ethnicity, and socioeconomic status are evident as early as infancy. Risk factors for obesity included diets low in fruits and veggies, low levels of physical activity, and inconsistent sleep schedules occur disproportionately among families living in low-income communities. So identifying key health habits, such as consistent bedtimes, may help families prioritize routines that promote healthy toddler growth and prevent excess weight gain. So in order to do this, it's important to look at multiple health behaviors over time to isolate between and within subject effects, which has not extensively been done among low-income families. So the aim of this study was to examine mechanisms linking poverty with toddler BMI Z-score, employing a comprehensive approach that included sleep, physical activity, and diet as mediators of this association. Specifically, we tested the hypothesis that family poverty is positively associated with poor diet quality, inconsistent sleep onset times, and low physical activity, all of which are subsequently associated with high toddler BMI Z-score. Longitudinal data were obtained from a randomized obesity prevention study. We recruited biological mothers and their toddlers from 2 sites that served low-income communities from 2007 to 2010, and all families were WIC eligible. 207 mother-toddler dyads were assessed 3 times over a year. Toddler sleep, including toddler sleep duration, total sleep duration, and sleep onset consistency, which we calculated as a standard deviation of sleep onset from night to night. And then physical activity were both measured with Actical accelerometers, which collect 24-hour movement data. Toddlers wore the Actical for at least 7 days at a time on their ankles. Height and weight were measured and converted into BMI Z-score, and mothers completed a 24-hour dietary recall for toddlers, and the 2015 Healthy Eating Index was used to assess diet quality. Household poverty was assessed using parent-reported income and family size to calculate a poverty ratio based on 2009 thresholds determined by the U.S. Census Bureau. So this is a figure to kind of display what the multi-level mediation looked like. So we conducted a multi-level mediation model to estimate the significance of the indirect effects of poverty on children's BMI Z-score through sleep onset consistency, diet quality, and physical activity using LM-MED, which is a new macro that was developed to compute multi-level mediation using SPSS software. ML-MED accounts for level 1, which is the within person, and level 2, which is the between person variability, and estimates all of these parameters in the model simultaneously. So we For covariates, we included toddler age and total sleep time in the analysis as level 1 covariates. And then for level 2 covariates, we added toddler sex and intervention group. At time 1, 70% of the sample was living below the poverty threshold. 54% of the toddlers were male, and the majority were non-Hispanic Black. On average, toddlers had 4.3 nights of valid ACTICAL data. Mean nighttime sleep duration was around 8 hours, and sleep onset consistency varied by about an hour and a half from night to night. And then average bedtime was around 9:30 p.m. For the between-person effects, we found that children from households with greater poverty had more overall inconsistent sleep onset times and lower diet quality scores across all time points, but they did not differ with respect to physical activity. And then children who had more inconsistency in sleep onset had higher BMI-Z scores across all time points. So sleep onset consistency sleep onset consistency is what significantly mediated the association between average poverty and toddler BMI-Z score, while average physical activity and diet quality did not mediate this relationship. For with in-person effects, we found that increases in poverty for a given family were associated with decreases in children's physical activity. Variations in poverty were not associated with changes in sleep onset consistency or diet quality. And neither sleep onset consistency, diet quality, nor physical activity mediated the within-person effect of poverty on BMI-Z score. So in terms of implications for our findings, our main finding that children who generally had more inconsistent sleep onset times had higher BMI-Z scores, even when accounting for total sleep duration, diet quality, and physical activity, is in line with prior work conducted among school-age children and adolescents. But our findings extend prior work by using objective measure of sleep and identifying this potential mechanism among a sample of toddlers living in low-income families. Given our findings, including a sleep routine as a focus of obesity interventions may have a positive influence on weight outcomes in early childhood. There are several recommendations of future research from our findings. First, the objective measurement of family routines, including meal times, diet, bedtime, and physical activity routines, could reduce the potential bias from parent report, and direct observations through video recordings or in-home assessments may be ideal for identifying consistent routines. Ecological momentary assessment, which is now often implemented using smartphones, could also be used to identify the frequency, time, and contextual variability of routines. As I said in my prior slide, based on our main findings, bedtime consistency may be a target for obesity prevention interventions, perhaps as a sole focus. And then finally, continued longitudinal research is needed to further uncover the contributory mechanisms underlying pediatric obesity. Experimental designs can clarify how environmental conditions that we didn't measure in this study could relate to pediatric obesity, and the potential roles of reverse causality and bidirectionality could also be explored. Because we know that obesity and related health habits such as diet and physical activity may also contribute to short sleep duration and late inconsistent bedtimes. So there's a variety of relationships that are at play here that need to be further explored. I want to acknowledge all my co-authors who I worked with at the University of Maryland School of Medicine, and this was funded by an R1 to the PI, Dr. Black. And I thank you all for your time and happy to answer any questions.